that thing has to be stopped. And I am again reminded of Sir William Osler, the secret of longevity is to contract a chronic, have a contract with a chronic disease and take care of it. And it means, what it means is that when you contract that disease, a chronic disease like diabetes, you have to take care of it by disciplining yourself. The lifestyle again, the diet, the exercise, and these things. So therefore, I always tell my patient, देखो भाई, diabetes हो गई तो this is a secret for you to live long. The diabetic can reach to any height as far as his career is concerned. He might live a full healthy life, provided we continue to take care of you, you discipline yourself. And by that I mean not only exercise, smoking, alcohol, keeping the blood pressure under control, and all these things. Now I would, Dr. Ratan Jha has come all the way from Hyderabad. What is your first advice that you would do as far as nephrology is concerned to a diabetic patient? What would you like to do?
A patient of diabetes with kidney disease, when he reports to me, first thing that I check is that is this patient having a diabetic kidney disease or a non-diabetic kidney disease, because the prognosis are different. A diabetic kidney disease is a diagnosis based on the circumstances of long duration of diabetes, eye changes, nerve changes, etc. In absence of that, we should always look for other clues to say that it's a non-diabetic kidney disease, because it will have a better prognosis compared to a diabetic kidney disease. So that's the first thing that I look at it when a patient comes to me. Second thing, that very important point I want to make for the physician, etc. This is a general feeling that this metformin is nephrotoxic. The moment diabetic kidney label is put, people try to remove this metformin. It is to be understood that metformin is not nephrotoxic. It has to be used with caution till the GFR is 30. After that, it is not recommended, but it can be used if it is required, and it's a good drug. This metformin is not nephrotoxic. Among the sulfonylurea group of drugs, if we have to choose as a nephrologist, the National Kidney Foundation recommends glycoside to be used as a preferential drug till the stage 5 is reached. But after stage 5, glycoside is not recommended and glipizide is recommended, because it has got no drug metabolite which remains in the system. So that is about the oral hypoglycemic drug. SGLT2 is a drug which is said to be a beta blocker for the kidney, because it is a drug, it reduces the metabolism in the kidney and protects the kidney. It is the only drug at the moment which is said to be nephroprotective. So this drug is to be used till the GFR is above 45. After that, the drug loses its utility in the context of kidney disease. And after that, the drug that can be used as per the leader trial is the GLP-1 receptor agonist, which has been found to be nephroprotective. Otherwise, no anti-diabetic drugs are found to be renoprotective. If I have to make a statement in the context of a DPP-4 inhibitor is cardio safe, renal safe. SGLT2 is this cardioprotective, renoprotective. Coming to insulin, if you are using a drug to reduce the glycemic variability, the long-acting drugs have been found to be quite useful. Insulin analogs are said to have lesser hypoglycemic risk if you are using the short-acting analogs in the context of advanced renal failure. SGLT2 inhibitor we have used without any kind of inhibition, even in patients on dialysis, because this is a drug which is not found to have any hypoglycemic effect. And vildagliptin being a drug which can be used in 50% dose, it becomes very cheap. And I have used many patients with this drug and found to be quite comfortable with this usage.
Any other comments about renal in diabetes? Any one of our